Loss of a child is surely every parent's worst fear, a profound loss. What if that child is an adolescent and they committed suicide? Welcome to Talking Psychiatry. In this episode, I will be in conversation with Mark Goldblatt. Mark is a psychiatrist and psychoanalyst, and he works in Cambridge, Massachusetts, in the United States of America. Mark is a clinical associate professor of psychiatry at Harvard Medical School and a founder of the Boston Suicide Study Group. Mark has an extensive list of publications which speak to his involvement in and interest with suicide. Let's join Mark and hear what he had to say. Mark, it's great to see you. Different time zone, different continent. In my studio, in my study, the miracle of technology as and when it works. So it's great to see you.
Hello, Christopher. Good to see you too. It's nice to be back.
Well, I had a look at your biography and I remembered, it reminded me, you studied at Wits, right? Your undergraduate medical training was right here in Johannesburg at Wits.
Yes, I graduated in 1981, and then I went to Groote for my internship. After my internship, I went to Boston to do psychiatric residency.
Well, we share the same alma mater, which is fantastic. So, Mark, before we dive into adolescent suicide, which is obviously the focus of our conversation today, and thinking about loss and parents who lose children to suicide, which automatically brings up the issue of survivors. I think we're going to get into the impact that suicide has. It's not just about the loss of an individual, but it's how it ripples through the entire family, social structure, community. But I wanted to just come back to you briefly. Suicide and psychoanalysis, that's a very interesting combination of interests that you have. Would you care to elaborate a little bit?
Well, it's something I got interested in soon after my residency, which is trying to understand aggression. How do we understand aggression against somebody else? And when does it get turned onto the self? And in suicide, people have usually unbearable feelings and they're not sure what to do, but it seems like one of the things that seems a pathway is that they attack themselves. Now that's quite interesting to understand. Why would somebody who feels so awful decide that the way to deal with this is to attack themselves? And so it's always been interesting to me to try and understand how these unbearable feelings lead to an attack on the body.
And do you have any theories, given that it's something that does interest you and you've clearly given it a lot of thought? Any specific theories on that?
Well, there's a disconnect. So some people, especially young people, some older in distorted states, think, well, I'll finish with the body, but I'll still continue. So some people believe spiritually I can continue, but some people, especially kids, believe it concretely. I'll die, but I'll be back tomorrow. And they don't quite get the finality of death.
Yeah, I think that's very powerful, actually, because I suppose at a young age, it's difficult to grasp that concept. I think as you get older and as you age and you see people around you die from within your peer group as you're getting older, you've lost family members, that concept of death becomes much more real and you've kind of lived through it through your experience, which maybe young people have not had. So maybe their sense of vulnerability as well in terms of illness and their physical health has not been impacted in the same way as when one is older, I suppose.
Well, yes, and it can be developmental. By that, I mean your age. So young people, especially in bad circumstances, they see a lot of terrible trauma things. They see their friends getting attacked. They might see their friends die. They see all sorts of bad things. And so they know about awful circumstances. But internally, they can still hold on to the idea of, and I'll continue, this lack of finality, that the body might go, but the self will continue in some way. And there's this disjunction between how I think of myself, my body self, and my person.
Okay, so you may have experienced it, but in terms of actually internalizing it as how it's going to impact on you, maybe, as you say, there's that disconnect. But I wanted to ask about psychoanalysis. Where does psychoanalysis fit into the psychiatric landscape of today? Because I've always understood that in years gone by, psychoanalysis was very much a feature of certain academic departments in North America, and of course, going further back. Where does psychoanalysis fit in today?
Well, psychoanalysis is a way of understanding the mind. So in psychiatry, we are dealing with different kind of illnesses, but we're also dealing with relationships. And psychoanalysis is one way of understanding relationships. Why are relationships so important? Well, part of the importance is how we take them in. So I feel we start off with the relationship to the mother and how nurturing that is. And if we don't have a good enough mother, which is a psychoanalytic concept that Donald Winnicott started with, we need a good enough mother to help us grow. And if you don't have that, then you start developing different ways of coping, which might not be so helpful. And then when there's stress later on in life, in adolescence, or say when your first girlfriend leaves you, or when you get bullied, there's less coping strengths. And people then say, well, I don't know what to do, and give up. So psychoanalysis is a way of understanding the way the individual copes and strengthening that. And coping is usually relational, either relationships from the past or the relationships that I have in the present. So to answer your question, it's a
Yes.
complicated idea that there's an unconscious. Now, not everybody believes in an unconscious, but psychoanalysis is a form of study of what's unconscious. And if you ask me what's unconscious, well, I can't say because it's unconscious. But there's a system that analysts have been looking at to try and define what is unconscious. And we see it, in slip-ups when we say things we don't mean, and we see it in dreams. Dreams are a way of recognizing the unconscious.
And you've used psychoanalytic approaches or psychoanalysis in terms of understanding self-destructive behavior. I understand that that's
Yes.
really something that specifically interests you. And your thoughts there?
Yeah, so that, to me, that's key. So why would, if if I lose my job, I would be hurt, and I would maybe be angry at my boss, or maybe I would want to blame the economy or something like that. I could understand that, but why would I turn that, and therefore I should kill myself? So that implies that there's something going on internally, that somehow it's switched from blaming the external world to saying, I'm no good, I've been found to be wanting, and nobody loves me, and I feel all alone, and there's kind of a hopelessness. And so trying to understand that mechanism of how did things switch from being hurt to feeling I don't know how to cope, to feeling the only way out is to attack myself and to kill myself.
Okay, so there's a progression from one thing to the next, which brings me to something that I wanted to tease out with you, because obviously in any given patient, suicidal thoughts, threats of suicide, suicide attempts, completed suicide. And so is there a continuum in terms of risk analysis with any given individual patient, or do these phenomena kind of exist as discrete entities, not necessarily one leading to the other, to the ultimate?
No, I think they are connected. Most people will at some time in their life think, this is too much for me, I want to die. So that's a broad range of the population. Then a smaller percent will think things are so bad, I want to plan for how to kill myself. And then a smaller percentage of that will go on and actually try. They'll buy a knife, or they'll buy a rope, or they'll buy poison or something like that. And then a smaller percentage, usually about 10% per 100,000, 10 per 100,000, actually go on to make a suicide attempt. The best predictor that we have of who's going to go on and try and kill themselves is a previous attempt. So if somebody's thinking about it and then planning for it, that's all makes us worried. But if they've actually tried, that makes us very worried. That somebody who's tried to kill themselves is at high risk, especially if they used a lethal means to try and hurt themselves in the past.
Well, I suppose they've shown a specific intent and capacity to follow through, maybe not to a completed suicide, but certainly based on an idea. And so I suppose my question is really how one interprets somebody who says, I feel suicidal in terms of risk, because one can have suicidal thoughts. What do they mean? And I suppose when I've worked with adolescents, often my understanding has been, I want change. I want things to be different. And so death is an option as opposed to that's the only way. And I've kind of looked at it like that. So one takes it seriously, but I think that for me, it's often not necessarily a threat that there's going to be a completed suicide. And it almost serves more as an entry point into exploring why that person would feel the way they do and express or have such ideas. Your thoughts on that?
That's an excellent point. So that is the most important thing, to get involved and to discuss and explore in your terms. So if somebody feels that they're hopeless and they want to die, that I would encourage people around them and caregivers, explore it, find out more about it. There used to be an old idea that don't talk about suicide because that will give people bad ideas. We don't think that's true. People have these terrible ideas. They think about it a lot. And the more they can put it into words, the more they can make sense of, why do I feel this way? The one thing that so Ed Schneidman was an important psychologist in the study of suicide in the 1960s in California. And the one thing he taught us is that all people with suicide are ambivalent, and especially teenagers and young adults. The wish for suicide is an ambivalent wish. And by that I mean, I want to die and I want to live at the same time. It's not,
Yes.
I do this and then I do that. It's at the same time I have both. And so talking about it helps me clarify the feelings of wanting to die and the feelings of not wanting to die, of wanting to live.
And I think that's a critical word, clarify, because I think in the conversation, what you're really doing is you're clarifying and you're putting it into perspective, and you're taking the thought, the feeling, and you're trying to make sense of it and move it towards something that is hopefully more constructive with a better outcome. So I think communication is actually critical, and as opposed to avoiding it, one actually steps into it and engages actively with it. So just talking about adolescent suicide, I mean, obviously it's always good to get a sense of what is the extent. Now, I've got some South African data for what it is. It goes back a little way. What are your thoughts around the extent of adolescent suicide in the United States and just generally?
It's a big health problem, and it's a big worry because it accounts for most of the deaths of, well, I think it's number 2 or number 1 of deaths of young people, either from motor vehicle accidents or assaults or from suicide. So it's a big part of what affects people. But before we get to that, I want to go back to
Yes.
a point that you just made earlier. So the talking about it is organizing. Now
Yes.
that's a psychoanalytic concept, that by putting my thoughts into words, I become more organized and I realize what I'm saying and what I'm desiring and what's affecting me and what I might do. So that's part of the psychoanalytic engagement. Talking about it, putting it into words, makes people more aware of what they're actually thinking and how they're planning for the future.
But I like that concept of it's organizing, because it sort of reminds me that when one is often confronted with a problem, the old pen and paper, where you sit down and you start to just jot down ideas. What am I thinking? What am I feeling? What are my thoughts on a specific issue? What are my options? What am I going to do? So yes, I think that organizing provides that clarity, and suddenly you feel much more on top of the situation because you've actually been able to map it out. And I think that that's a good word, organizing. I like that. So coming back to the issue of extent, I mean, just to echo what you were saying, I mean, the World Health Organization would say, or has said, that 1 in 12, 10 to 19-year-olds have a mental disorder. That's a significant number. Second leading cause of death in 10 to 14-year-olds. Third leading cause of death in 19 to or 15 to 29-year-olds. So kind of echoing what you're saying. It's right up there as a cause of death. Certainly in the South African situation, 9% of all teenage deaths. This is from the National Injury Mortality Surveillance Study, but it goes back to 2007. So 9% of all teen deaths were by suicide. 1.6% between the ages of 10 to 14, and 8.4% of all deaths between the ages of 15 to 19. That's I think, a significant percentage.
It's very high, and it's very disturbing, and dealing with it is complicated because it's so multi-determined. It's not
Yes.
just one thing causes it. I lose my best friend, or I got kicked out of school. It's not one thing. It's multi-determined, and it usually arises as a crisis of development. So there's a precipitant, usually a loss
Yes.
or an attack, and it comes at a certain time in one's development. And the difficulty with these young people is that they don't have internal resources. So after you've grown a bit, you have a capacity to deal with bad things. At 12, 14, it's very difficult to deal with these things, and you need people around you. And if your family has somehow abandoned you, or isn't around, or is attacking you, it makes it very hard to deal with these stresses. And that puts people more at risk.
So I suppose one is looking at the issue of coping skills and problem-solving capacity, where it's because of your lack of life experience, problems seem overwhelming, and that in fact there's no alternative but to potentially do something with to yourself, not with yourself. Well, it is with yourself, but to yourself. But as you say, it's multi-determined and multifactorial. So maybe we can talk about that. Risk factors for suicide, because I think at the end of the day, there are many. But a quick question. Do you think it's on the increase? Because I think that is part of the concern, is that this appears to be an increasing phenomenon, certainly in Western urban society. I don't know, is that your sense of where we are?
It could be. I think COVID was a big stressor. Now, COVID made people feel more alone and isolated. And like I've been saying with suicide, you get cut off from support systems. And if you're dealing with things on your own, it's much harder. So since COVID, we've become engaged with people again, but the effect of being isolated still lingers. So yeah, I do have a sense that well, there's a couple of things going on. People are communicating their distress more openly, and that brings us to the internet and social apps. So when people were feeling terrible and were thinking about suicide in the past, they might have just thought it over and maybe mentioned it or not mentioned it. Nowadays, a lot of people are writing about it on the internet, and reading about it and hearing more about it tends to energize it and make people think this is the way to go. So that's part of the problem in making it um, more available, more
Option.
common as an option. And um, denying the support that people can get. So it both increases the thought about it without increasing the solutions.
Well, I think that
As
you're
long as we
speaking
can,
about. Yeah, sorry, Mark, carry on.
as long as we can increase the solutions, the support from outside, I think we can allay those fears about suicidal planning.
Well, I was going to say, I think that we're speaking about a very specific context, which is not necessarily an empathic, supportive context, which is what we're talking about in terms of communication and, verbalizing one's thoughts or feelings or distress. I'm not sure that social media is necessarily the appropriate venue for that, but I'm going to get into social media a little bit later because I really do want to focus on that. But there were some other statistics which I got, strangely enough, coming back to stats from the World Bank, and I'm just looking at the Anglosphere, the English-speaking countries, and this is from January 2026. Between the ages of 15 to 19, New Zealand, data that goes back to 2018, 17 suicides per 100,000 in that age group. Australia, from 2023, 8.9 per 100,000. The USA, 2022, 10.1 per 100,000. Canada, 2022, 7 to 8 per 100,000. The UK, 2021, 6 per 100,000. South Africa, 2020, 0.4 per 100,000. So there's a very interesting distinction between what's happening in South Africa, and yet, we are obviously concerned because it's affecting our youth. But when you put that figure in contrast to the Anglosphere, UK, Canada, America, Australia, New Zealand, there's quite a significant disconnect. So my question is, what is going on in the Anglosphere?
Well, we don't know exactly, but I can suggest a couple of things.
Yes.
So one thing is the availability of means. So if people can find a way to jump in front of a train or jump from a building or do something that's going to kill them, then it makes the risk of suicide higher. There's something protective in the data you're showing from South Africa that's very interesting, and I wonder what that is. Either, my bias is to say it's family, it's connections, that there must be some support systems that help people, but I don't know that for sure.
Well, I think that we probably overall still have a more traditional society. And I think the bonds of family potentially are much stronger in the various communities that make up the South African population. And certainly, I think that that must be a factor. Having said that, I mean, there are many social problems in South Africa, but obviously not necessarily contributing to the kind of suicide data that we're seeing in developed countries amongst 15 to 19-year-olds. So I'm not sure that that's been fully explored or teased out. And as I said, I've just come across this information, and the distinction is actually quite stark. So there's something there that needs to be looked at, because I think as much as one talks about completed suicide and risk factors for, one also needs to look at protective factors, because I think that's very important. And I think that's what you're alluding to, or what you're saying, actually.
Yeah, I think one of the big protective factors is having other people involved in your life, whether it's your immediate parents or your siblings or your extended family or your community. But having people involved in your life, I'm quite certain is very protective.
Well, certainly one of the risk factors is conflict with those very people, peers, parent-child, often parent-child dynamics. So I think that when one looks at risk factors, conflict is often a precipitant of a suicide attempt, not necessarily a completed suicide. Your understanding of that?
Now, conflict there's two sides to conflict. So if I'm fighting with my mother, it's a way of saying, I don't like what you're doing and I don't like what you're doing to me, but we're still engaged in this, we're engaged in this conflict. When people feel hurt and abandoned, that's more likely to cause a suicidal hopelessness. So there's something about engaging in conflict that keeps people alive and going on, even under terrible circumstances. But unbearable abuse, sexual or physical trauma, is then makes it untenable, and people feel they can't go on, especially if there's no one to talk to.
I think that what I'm understanding, and I suppose it's the same for most things, it's generally not one thing. It's one thing, but within a broader context of other things that kind of come together in a final common pathway where the person makes a decision, I can't do this anymore. And I think that you've alluded to that, or you've mentioned that the issue of pain and the distress that the person is experiencing as almost like a final common pathway to get to the point where it's, okay, this is what I'm going to do.
So I mentioned Ed Steidman, who was a suicidologist in California, and he liked to neologisms. He liked to make up names.
Okay.
And he made up the word psychic. So psychic is the kind of mental anguish that everybody who's thinking about suicide will describe. And they'll say that the immense internal pain becomes unbearable. And I think that's true. I think that's a real phenomena. And when I'm talking to somebody who's been thinking about or tried to kill themselves, I ask them about internal pain, and they'll very quickly describe it, how immense it is and how unbearable it is. So dealing with this internal pain is one of the important things that we as therapists can try and alleviate.
Yes, I think this notion of mental anguish, it's a very powerful term, but I wanted to just come back to the data to just say there's data and then there's individuals, because one can get lost in the data and it becomes an abstract concept. But in actual fact, we must never lose sight that irrespective of the fact that it's 0.4 per 100,000 versus 17 per 100,000, there's still 0.4, which means there are youngsters who are killing themselves, and that is tragic at the end of the day. So I think that one must be careful that the numbers don't create a sense of, well, we're not as badly off as them, therefore there are still individuals involved.
Very good point, that each person has to be taken individually, one at a time. And for each person, the risk really depends on what's sustaining them, what's helping them keep connected to life, and what's devaluing their connection to life.
Yes.
And one of the things that takes away your connection to life is trauma. People who go through assaults and unbearable physical things have a difficult time continuing, but it's also attenuated by drugs and alcohol. So when people are taking meth or alcohol, drinking, that makes your your capability to attack yourself much quicker. People it's very difficult to actually hurt yourself. But once you're drinking or taking things like meth or cocaine, it crosses that barrier much easily.
So substances kind of lower the threshold, in a sense, for moving into that kind of situation. And so substance abuse is itself a risk factor. And you've given a very cogent reason as to why that might be, aside from the disinhibition that may take place.
Yeah, it puts you much more at risk. And some substances are really, they increase aggression. And meth is one of them.
So tell me,
PCP
the
is
issue of
another.
PCP. Yeah, not, and that might be an issue in the South African context, the availability of certain substances which are maybe more readily available in different contexts than in the South African context. So that might be a possibility. But adolescence as a vulnerable period in terms of impulsivity, where does impulsivity fit into the picture?
Well, that's such an interesting point, because adolescence is a time where the constraints on impulsivity tend to be loosened. Older people will think it over more. Adolescence, you feel you have to act quickly, and that's a danger. Now, impulsivity can be I want to kill myself, I'm going to act. And you can wait a day or two because you know you're going to act even in 2 days' time when everybody leaves the house, and can be an impulsive decision that I'll do something when everybody leaves the house on the weekend. Or it can be I've just been I just found out my partner is cheating with somebody else and I can't stand that. I'm going to go and jump off the building. So impulsivity is an inability to think through what terrible things I'm facing and feeling that I can't face them all right now and never will.
So I suppose at some level it also comes back to that capacity to problem solve, where you can say, I'm feeling overwhelmed. I'm not going to act because I need to really unpack that and understand where's it coming and what are my options in terms of how I deal with it. And I think that's where conversation is so important with a trusted person, be it a psychotherapist, a family member, whoever, where you can actually, as you've said previously, organize your thinking in terms of where am I at? Where would I like to be? Because I think that's also very important. I'm very distressed. I would prefer not to be distressed. So killing myself is a possibility. How else might I get to a position of not being distressed and living the life that maybe I would like to live?
Well, I hear what you're saying, Christopher, and you're sounding like a grown-up. So that's a very mature way of approaching it. And the trouble is, when we get into a crisis, it's hard to think like a grown-up. So if I see my partner with somebody else, or I didn't get the job that I wanted, or I see my father beating up on my mother, in that crisis moment, I'm not thinking, and I just feel so awful. And how can I find a way to just hang on? And is there anybody I can talk to while that's going on? That would, I think, be more sustaining. Finding a therapist would be a good thing, but it would take a little bit longer. In the midst of a crisis, I'm suggesting try and find a sibling or a friend
Yes.
or a church person or somebody like a teacher if you can.
Well, I suppose that's why I was talking about a trusted person, because as you say correctly, I mean, finding a psychologist, a psychiatrist, a therapist, that unless you already are in a therapeutic relationship, I suppose what I was talking about is a process, as opposed to this is how I'm going to portray it to you and okay, you'll get it. Because I don't think it works that way, to be honest with you. I'm thinking more along the lines of that's the kind of process one would like to follow. But as you say, it doesn't happen quickly and one needs to be engaged. And I suppose a trusted person. And that's, where the issue of being alone and lonely is a particular risk factor for the person who has maybe suffered trauma or whatever it might be.
There's two aspects to that. Being lonely is very difficult, especially when you're going through a crisis. However, you can be with your family and feel very alone. In other words, I can't talk to them. They don't understand. There's people around me, but I don't feel connected to them. And that feeling of aloneness is even more difficult. It's hard to break through that, even for therapists to break through and to get to change that sense of feeling so alone.
Well, I suppose that brings me to the issue of relationships and the loss of a relationship as a precipitating factor, because I think that is also the loss of a romantic relationship, the loss of a loved one, a mother, a father, a brother, somebody close to you, also a potential risk factor.
Yes, we think loss is a very high, very important risk factor. And sometimes the loss means more than just the loss. So if I lose my first partner, it's not so much that loss of that person, which is huge, but it can also make me feel, and I'll never find a replacement. I'm going to be lonely for the rest of my life. There's a distortion that goes with it. So that contributes to depression. So people who find themselves in a depression often have had a loss, And you could say, well, you lost your job, and maybe that's contributing to it. And they'll say, well, yeah, but I didn't like my job anyway. It, it's the loss of the actual thing and its meaning. And the meaning cannot be, can be difficult to tease out, because it can be something like, and then my parents will think I'm no good, and that I've never been able to prove myself, and that just shows that I'm a bad person, and I'm not going to be able to take care of myself in the long run. There's all these distortions that go along with it. And trying to deal with those, I would say, unconscious distortions are what can be therapeutically helpful.
I think that concept of distortion is a very important one, because I think that's really, I wouldn't say it's at the heart of it, but it's a very strong contributor. There's a distortion in terms of what you've experienced, what it means, and what you're going to do about it. So I like that word. And to me, it's very descriptive, actually.
Yeah,
You
and
mentioned
it's a distortion in thinking.
Yes.
So that's a difficult concept that we're coming up against, a distortion in thinking. I see things, it should mean one thing, but I distort it to say it's got all these horrible implications, and that causes the recipient to react self-destructively. There's a distortion in perception and dealing with it.
And that's where we talk about cognitive distortions. For example, selective abstraction. You make one thing everything, as opposed to just seeing it in context. And I think that's always very important to contextualize. But you mentioned depression, and obviously I need to look at the diagnostic entities, psychiatric history, current psychiatric history, diagnosis. To what extent is diagnosis a risk factor in itself?
I think it's huge. I think most people who try and kill themselves or end up or think about it are going through a depression. And by depression, I don't mean just a bad mood, feeling low. Depression in psychiatric terms has a broader context. It's low energy, disturbed sleep, disturbed appetite, a sense of helplessness, loss of hope, and withdrawal, and of course a depressed mood. And all these things, when they go on for days or maybe weeks, they eat away at your reserve. And so you have less capacity to deal with life, and people end up taking to bed, they end up withdrawing, they cut themselves off from their friends, their parents will say he never comes out of his room. They might start drinking as a way to help them feel better, drinking alcohol, which of course makes it worse. Smoking marijuana can also make it worse. And so there's a cascading effect. And most depressions, no, I put it the other way. Most people who end up trying to hurt themselves are depressed and have some sort of psychiatric illness going on, particularly an affective disorder like depression. Some
Yes.
people have other issues going on, psychiatric issues going on, like bipolar illness, but not so much attacking themselves. They attack themselves more in the depressed state. And people with distorted thinking in schizophrenia can also be at risk for suicide.
Absolutely. And I was thinking specifically when you mentioned bipolar, I mean, manic patients are often highly irritable and they can become dysphoric. So it's not to say that I think there's maybe a perception that mania is equivalent to euphoria, which, yes, can be part of mania. But certainly you get the dysphoric manic who might also be at risk because they're highly energized, they're dysphoric. It's a potentially lethal cocktail.
Yes. Yeah, this irritable manic state is a very dangerous state. And it makes me think of another dangerous state, which is a psychotic depression. People who get into a depression and have a distortion to the extent of hearing voices saying that they're bad, hearing the devil talk to them, things like that. That's a very dangerous suicidal state. And the reason why it's dangerous is, number one, it leads them to action. And number two, they hide it. They know there's something wrong with the devil talking to me. That they know it doesn't sound right. And so they hide it from their friends and family, and especially from their psychiatrist and treaters. And that's what makes it such a difficult state to treat.
Well, and I think that, as much as there's a common understanding of depression, schizophrenic patients also commit suicide, and they can be driven to suicide exactly as you are saying. Certainly, if they've been paranoid and they believe that they are at risk or under threat, and we've seen examples of that. Certainly, I have. I wanted to ask you about gender. Is there a gender distinction in terms of risk for completed suicide and suicidality generally?
Seems like boys are more likely to kill themselves, girls are more likely to self-harm. And that goes from young teenagers to emerging adults, later teenagers, 20-year-olds, and maybe even 30-year-olds. That the males are more lethal, and once they decide, they tend to use means that are very dangerous and can be undone. Females tend to suffer just equally, but they seem to be focused on self-harming, which is different from trying to kill yourself.
What about pressure to succeed? Because we live in a very competitive environment. There is a need to achieve certain milestones and to achieve at a certain level in order to move forward. Do you see that with adolescents in terms of feeling helpless, hopeless, potentially suicidal, that pressure to succeed?
The adolescent goal is to grow and to become autonomous and to become the person that I want to be. And when the when society blocks you, then I can't get there because I don't have money. I can't get there because I don't have friends. I'm supposed to be supporting my partner by buying presents or buying food, and I'm not. I don't have a job. I'm not doing that. So those ways of not succeeding developmentally are extremely powerful in making people feel I'm no good. I don't deserve to even live. They'll be better off without me. The pressure to succeed and being a good enough person is high on the adolescent and needs agenda. And so often what you see on television and on the movies is unrealistic. So people think that at this stage of my life, I already should have accomplished. I should have got a job. I should have saved some money. I should be driving a car. I should. And I've not got any of that. And then the self-judgment kicks in. It makes me no good and undeserving, and I've let everybody down. And that contributes to a sense of depression.
The issue for me is one of comparison, and I think comparison is a very powerful underminer of often self-esteem and self-worth, and one then moves along that path if one is not careful. We spoke about access to means, and obviously there are various means which seem to also play out in terms of gender. Males more likely to hang themselves or to shoot themselves. Women, females more likely to use poisoning or overdoses. And that kind of plays out.
Yeah, you can be saved from an overdose if somebody finds you and helps you vomit it up. And usually the emergency room can help with Ipecac or something that causes vomiting. You can't be saved from a gunshot. You can't be saved from jumping off a high building. Those things are lethal. And unfortunately, if the males are more likely to choose these lethal means, hanging is a terrible way of going. You can't be, there's no going back. There's no saving from that. These are terrible outcomes that are very difficult to grieve when the family finds out.
Well, I think that, when you contemplate what we're talking about, shooting yourself, hanging yourself, jumping from a building. There was a recent case of euthanasia in Spain involving a young woman. She was paralyzed, a second suicide attempt. She'd been gang raped and she'd attempted suicide twice. The second suicide led to her becoming a paraplegic, and she requested euthanasia because she could not bear the suffering. And there were two psychiatrists who actually recommended it. It was quite a controversial case. It went to the European Human Rights Court, and they ruled in her favor. And so she died fairly recently. I think it was in February, March of this year. So that the whole issue of jumping from buildings and the consequences of a failed suicide attempt cannot be underestimated as well.
Right. But you're reminding me of the current debate throughout the world on assisted suicide. And Canada is one country where, especially in Quebec, they've changed the laws that people who want assisted suicide can get it, even if there is under any circumstances. And then the legislature took up the question of can they get assisted suicide with psychiatric illness, and that's currently being debated. I think it was delayed, but your case that you're referencing in Spain has the same issues. Can people who are suffering and have a mental illness make an informed decision about asking for assistance in death?
I find it a very troubling development, and I think the Canadian psychiatrists certainly pushed back. That's why it's only coming to the fore in March of next year, but there's going to have to be a decision taken as to, I mean, if you look at maids in Canada, approximately 5% of all deaths are maids. So there's quite a significant number of Canadians opting to end their lives with assisted dying. One can call it euthanasia, assisted suicide. It's a question of who's going to actually pull the plug, so to speak. There's one aspect which we didn't cover, and that's bullying, because I think that bullying is a particularly pernicious aspect of adolescent life. Your thoughts on that, because that's going to bring me to social media, and I think that is something which we do need to drill down a little deeper into.
Bullying is feeling that people are hurting me verbally or physically, and I don't have a way of fighting back. I don't have a way of resisting, and I don't have a way of stopping it. And so that kind of attack, I would call it trauma. And when trauma builds and builds, then eventually people feel this helplessness that suffering will always continue. I'm not going to be able to get out of it. And the only way to stop this is to die. Now, this goes back to the question that we were talking about right at the beginning. Why do people who have been attacked turn and attack themselves? Think if somebody's bullying me, I would want to do something to them. But that's got to do with the sense of helplessness. I've been so badly hurt. I've lost all hope of ever changing anything. There's nothing I can do. The only thing I can hope to do is to attack myself. So bullying has a very pernicious effect that has to do with a helplessness and a distortion, that there's nobody who can intervene, there's nobody who cares, and I'm back to feeling all alone without anybody to support me. I can't talk to anybody about it.
Do you think that social media has exacerbated that, has contributed? I'm going to refer now to a psychologist at New York University Stern School of Business, Jonathan Haidt. I came across him, and he published a book in 2024 called The Anxious Generation. And I came across an interview. For some reason, I printed it, obviously realizing that at some point in the future, because the interview was in November 2023, and here I am in 2026 referencing it. And he had some very specific thoughts on social media. And I'm just going to run them by you and see what you think, because actually he was quite prescient. And he said there were 4 things. No smartphones before the age of 14. No social media before 16. No phones in schools. And interestingly, more unsupervised play. He felt that kids were spending too much time in the company of adults and would do better to spend more time amongst each other away from adults. But put that one to the side. The issue of smartphones and access to social media. Your thoughts on that? Because in Australia, they've banned social media for, I think it's the under 16s or it's the under 18s. But about 60% of the teens are bypassing the ban already. But certainly there's a move to limit social media access for teenagers.
That ship has sailed. I think that's very nice advice, and it would be lovely if we could institute it, but that is gone. I don't think kids can be stopped from getting smartphones. They're too smart. They know what it does. See, the thing about the internet generation is that it helps people connect. You get connected not just with people who think like you, but people who don't think like you. And it's got its downside where people who don't like you can attack you, and there's very little restraints. Normally in face-to-face, we don't say bad things because we know enough to hold ourselves back. On the internet, it can bring out the worst in people. The good side is that people who feel all alone can find a place for themselves. I've had patients who I thought would never find a partner for whatever reason. They go on the internet and they start dating. They find people. It's just remarkable to me. So there is a good side. The bullying side and the lack of constraints is very worrisome, especially when there's lack of thoughtfulness about if you say to somebody, go ahead and do it, that can be very damaging. So there's both the attack, the bullying, and the encouragement. That's the downside. But the support that people can get is very helpful.
Yeah, which brings me to, I wanted to touch on artificial intelligence and the use, of artificial intelligence in terms of help seeking and seeking comfort. What are your thoughts on that? I know there's some very specific rules and regulations and laws in certain of the states in America that have outlawed any psychotherapeutic use of AI. But your thoughts?
It's a very interesting topic, and I don't know where it'll go, but I know that for two people to engage, two people to talk to each other, it's intersubjective. So I'm talking to you and you're talking to me. There's a way that the two of us are relating. That's what happens in psychotherapy. There's two subjective beings relating. Can AI do it? Well, to some extent, but I'll give you an example. So I went on vacation and I missed a session and I came back. And my patient said, well, while you were gone, I asked AI what I should do. And I said, well, what happened? And she said, AI said, Dr. Goldblatt would say. And so she was able to reproduce. Now, normally, without AI, my patient would say, oh, and I'm not sure what to do. Dr. Goldblatt always tells me I should, blah, blah, blah. So people have an own way of internalizing, and maybe AI just enforces that.
How did AI know what Dr. Goldblatt would say?
Well, obviously, she downloaded some of her sessions with me.
Oh, okay. So she had given AI the data, because obviously that is the lifeblood of AI, and she trained AI to be Dr. Goldblatt, actually. That's interesting. You've been replaced, Mark. That's, gee whiz. I didn't think that was possible in our field. I think, though, the one issue that you spoke about when you said the ship has sailed, I mean, you're saying that, listen, government attempts to regulate social media access. That's a little bit, closing the door after the horse, or closing the barn door after the horse has bolted. But there was another side to that. And some people felt that government involvement in that kind of legislation was actually reducing the agency of parents. And I think that effective parenting is a very important bulwark against the kind of distress and the kind of consequences that we've been speaking about.
Parenting is relating to your kids. And the more you can relate to your kids and not leave them to AI and the smartphones, the better they are. It gives you a chance that they'll come and talk to you when they need you.
Well, I think the key issue is communication, and I think that is obviously something which is probably a contributing factor to mitigating risk and constructive communication. I alluded to the issue of survivors and the impact that suicide has on those around them, and your experience of that, how it impacts parents, siblings, and the treating, if there is one, the treating psychiatrist or mental health professional.
It impacts enormously. I want to go back to quoting Ed Schneiderman because he's done a lot of thought about this. He said the death of a loved one puts their skeleton in the survivor's closet. You never really get over it. You've always got the skeleton in your closet. And I've had patients who say, well, my family, well, it'll be hard for them, but they'll get over it. Talking to survivors, people don't get over it. It's just such a horrible loss that people just don't get over it. It's very hard to recover. People think about it and try and make sense of it. And even if there's a note, they go over the contents of the note and try and make sense. It's the burden of being a survivor goes on and on for many years and maybe forever. The problem, in addition, is that survivors also start to think, well, maybe they had a point and maybe I should do the same thing. And that's dangerous, that they can become suicidal too.
So I think that yeah.
Go ahead.
Sorry. No, you carry on.
So the consequences are long-lasting and can be quite dangerous to survivors. The death of a loved one affects people for a long time.
So I think that certainly as a mental health professional, psychiatrist, psychologist, one has to be cognizant of those left behind as much as the person who has killed themselves, and they may need particular support. And I suppose support groups, if they do not want individual therapy, are a very important source of comfort, would you say?
Absolutely. So support groups can be great. They can really be very helpful. Samaritans is a worldwide organization that helps people who are thinking of suicide, also helps survivors. In America, we have the American Foundation for Suicide Prevention that also provides support groups. And the American Association for Suicidology are two organizations. But local support groups are very useful. People find a way to at least put into words what their loss means. I think we're back to articulating and organizing your experience. And it's very hard to organize your experience when you lose a loved one and you think, what could I have done? What signs did I miss?
I think that's really the issue. And I was going back to our previous podcast with Mariska Nell. She was a mother talking about the loss of her son who'd shot himself. She found him in the bedroom. This was 10 years later that we sat with her to do the podcast. And she spoke about that suicide note and the fact that it took her completely by surprise. They had no understanding that, her son was in such a state. And the note, as she read it and as she looked back, she could see there were signs. But I must say, she had moved from a survivor into a helper, and she had taken on the role of a counselor, a grief counselor for folk who had lost loved ones to suicide. So she was quite a remarkable woman. Do you remember that, Mark? I don't want to put you on the spot.
I do. Yeah, I do remember. It was very powerful, both the loss and how she had become energized by that to wanting to help both herself and other people. The idea is that if I can help other people not go through this, it will be have meant something, because the loss just feels so unbearable.
So I want to close talking about something which I suppose people might be asking: can we prevent suicide, and the issue of suicide prevention? Because there's a lot written about it, there's a lot said. But despite all of our best efforts at many levels, it doesn't necessarily seem that the incidence of suicide is diminishing.
It's been fairly fairly constant in most places, around 10 per 100,000, a little bit more in some parts of Europe. It goes up to 25 or 40 and down to about 9 or 8 in different parts of America. How to explain that? Well, I don't know. I don't know how to explain that. I think suicide is preventable. The trouble is most people don't share their concern, their pain, and their worries about thinking about it. And so if we can make it more acceptable to talk about your distress, I think we can go a ways towards preventing suicide.
Yes, and I think it's about our capacity or the ability to hold someone in a situation where you can actually talk it through before they get to that point. And I was just reflecting on the myriad of risk factors that we've discussed in terms of adolescent suicide. And as much as that might seem overwhelming, what it also says to me is that there are many points of entry that one might be able to better control, which could in fact mitigate risk. So as many factors as there are is also as many points of entry as there are into potentially mitigating.
Yeah, the big point of entry is discussion, talking to people, finding a way to have a conversation.
And I think that for me is a very clear message that comes out of our discussion, is that in fact it's not something that should be avoided. It's something that should be actively spoken about. So engagement is critical. Mark, I want to thank you for your time. I think there's a lot for people to ponder who'll be viewing this. I don't know that we've necessarily answered everybody's questions that they might have in their own mind, but I think that we've provided a very broad scope of issues within the specific topic. So it's been great seeing you, great talking to you again, and hopefully we'll talk again in the future. But I wish you all the best, and thank you so much, Mark.
Thank you. Thank you, Christopher, for having me on.
Thank you for being part of this conversation, and more specifically, for being part of this journey for Season 1 of Talking Psychiatry. We'll be taking a short break, but look forward to seeing you again in the not-too-distant future. Until then, please feel free to comment, do subscribe, and as always, take care.